Welcome, everyone, to the second segment of our series of Sound Mind. This series is sponsored by the Stanford Alzheimer's Disease Research Center, and it focuses on healthy cognitive aging and dementia. Tonight, we're going to go more deeply into the topic of dementia. What is it? How does it differ from normal aging? How do we evaluate if a person has these kinds of problems or not? And what really is the Stanford Alzheimer's Disease Research Center? What does it do? And how can we participate in the research that it sponsors? I'm your host for this series. I'm Dr. Dolores Gallagher-Thompson. I'm a clinical geropsychologist and professor of research in the Department of Psychiatry and Behavioral Sciences at Stanford. I am joined by our very special guest, Dr. Victor Henderson, who is the director of the Stanford Alzheimer's Disease Research Center. Dr. Henderson is also professor of neurology and of health research and policy. We're very pleased to have you on the show, Dr. Henderson. And tonight we're going to start off by asking you to help the audience understand what really do we mean by the term dementia.
Well, thank you. I'm very happy to be here, of course. And dementia is a term, an older term, used as an umbrella term, and it implies a loss of cognitive abilities, but a loss that reaches a level where it has an impact on daily function, day-to-day functioning. So it's a cognitive loss that has a daily impact.
Mm-hmm. So is dementia the same as normal aging?
No, I think conceptually and in reality the two are distinct. Sometimes it's hard to tell one process apart from the other, but they are separate, I think.
Did you have a graphic that you wanted to share with the audience about the difference between cognitive aging that's healthy versus when it turns into dementia?
Well, I think for cognitive aging, we should point out that cognitive abilities normally vary over the lifespan, and we have a graphic to illustrate that there are different kinds of cognitive skills. Some tend to get worse with age, some don't. And for example, there are skills related to knowledge, information, to how to approach certain problems. These are things that tend to get better throughout most of a lifespan. It's the kind of skills we associate with wisdom. When someone is wise, they have experience, they have knowledge, they know how to approach things. But there are other kinds of cognitive abilities that don't tend to get better. These are things related to facility learning new information quickly or promptly, the ability to manipulate information, to change directions in a complex environment. And these kinds of abilities, as illustrated on this slide, are the kinds of abilities that tend to do worse with aging. The decline doesn't start in late old age. It doesn't even start in middle age, but actually starts earlier in adulthood. The important point is that the declines that we see in those other kinds of skills don't reach a level to have an important impact on day-to-day function.
So it's fairly complex, isn't it? That some skills may remain or even improve over time, and other skills we might find a deficit. But it does sound from what you've said that not all people inevitably develop dementia. Would that be correct?
Oh, by no means. Dementia gets increasingly common with age, but certainly by no means has everyone developed dementia.
Now, is Alzheimer's disease the same as dementia? Because a lot of people talk about Alzheimer's disease these days, but I wonder, are they synonymous, those terms?
No, dementia is sort of a broad umbrella term, and Alzheimer's disease would be one specific cause. It's the most common cause. It's the most important cause, not only because it's most common, but because it's a progressive disorder that ultimately leads to fairly severe disability. And there are certain microscopic changes that would be indicative of this disorder that are distinct from the changes seen in certain other dementing disorders.
So what are some of the other common types of dementia?
So maybe we can look then at the second illustration, and
All
the
right.
top part of that would indicate that the processes I think that are associated with normal cognitive aging are different from those associated with dementia. They don't eventuate in dementia, but abnormal cognitive aging implies the underlying changes of Alzheimer's disease or some of the other causes of dementia, like blood vessel disease leading to vascular dementia associated with strokes or other vascular abnormalities. There are changes referred to as Lewy bodies, which in the brainstem, a part of the brainstem, can cause Parkinson's disease, but in the cortex can lead to a different form of dementia. And there are other changes associated with the so-called frontotemporal dementias. The important point is, anymore, the neuropathologist is able to identify a cause or an overlap of cause for almost everyone with dementia. So normal cognitive aging would refer to the kinds of changes that don't lead to dementia, that aren't associated with these causes of dementia, but the processes with dementia are distinct.
Okay, so it sounds like there are definite brain changes that are associated with Alzheimer's and with these other forms of dementia.
Absolutely.
Yeah, so that would mean that it would require a specialist probably in order to be able to do a thorough evaluation.
I think it requires someone who has experience with this, so quite often that's a neurologist, but sometimes a geropsychiatrist or a geriatrician or even a family physician who is sort of focused in this area can do a good screening examination.
So if I were concerned, I think you mentioned memory loss as being a cardinal feature of Alzheimer's disease. So if I were concerned about my memory, let's say, and maybe I'm just not doing things as well as I used to. So I'm starting to get worried about this, and I read about it in the newspaper. So when would I want to go see my doctor? When should I be worried enough that I would actually go to see my doctor?
It's a good question. It's a common question, and there perhaps isn't an easy answer. The Alzheimer's Association has provided a list of early warning signs, and that would be illustrated in the figure up there. And I won't go through the entire list, but I think most important among these would be memory loss. Now, I would point out that all of us are forgetful from time to time. We forget names. We might walk into a room and forget exactly what it was that we intended to do there. But the kind of memory loss that seems more worrisome is the kind that reflects new learning and the ability to remember something 5 minutes, 5 hours, 5 days later. So someone who repeats questions, who can't remember appointments, has to use lists and is sort of lost without lists. That would be sort of an indication that maybe there's something going on that exceeds what is expected on the basis of usual cognitive aging.
So these would be some of the signs that I would look for, or a family member might look for in me if they were getting concerned about me.
Right, and certainly not everyone with concerns has early dementia, but it's a reason to seek evaluation to find out if there's something more important going on.
So if I went to my doctor, and I expressed these concerns, and maybe the family member did as well, what would be done? What kinds of tests, or how would the evaluation be conducted?
So there's a simple outline that I've made, but I think the most important part comes from the history. The information provided by the patient herself or himself, and also by a family member or other informant. And the reason why the informant is important is that sometimes people don't know what they're not remembering. And it's sort of good to have another perspective in that and to provide that point of view. On the other hand, a lot of us notice small changes that occur with normal aging, become overly concerned about, and the family member can provide a different form of perspective. They might say, yes, I do notice she's a little bit more forgetful, but so am I, and so are all of our friends, and what I'm seeing here is no different than any of the rest of us. And that perspective is important as well.
So that could be reassuring. So just because I'm worried about my memory and my cognitive function doesn't mean I have dementia.
Oh, by no means.
Yeah.
And the history would then be followed up by an examination, a physical examination, a neurological examination, some sort of testing of memory and other cognitive skills, some sort of assessment for mood, because depression often is associated with some cognitive slowing, as well as increased concerns about one's cognitive abilities. If there is additional concern, then laboratory tests are often done.
And I've read that a lot of people get MRIs these days. So is an MRI fairly typical also? And what would that be used for? What would the MRI provide?
I think an MRI is useful, or a CT scan, if there is concern that there's something going on beyond normal cognitive aging. So an MRI provides a structural image of the brain and would provide information about some other disorders that can affect cognition. It wouldn't show Alzheimer's disease specifically. It's more important in ruling out other possible contributing factors.
So does it ever happen that some of these changes that you see might be caused by something other than a dementia?
Well, I think it's quite common for people to be concerned about memory, and there is no dementia there. And there are also other things, of course, that might be going on. Some of these aren't so common, but sometimes nutritional deficiencies, B12 deficiency, for example, endocrine disorders like thyroid disease can affect cognition. If someone does have dementia, it's certainly not always Alzheimer's disease, and these other tests help try to narrow down or focus on what the underlying disorder really is.
So it sounds like perhaps some disorders can be treated if it's not Alzheimer's, which there is no effective treatment for at the present time, I understand. But if it were something other than that, and these tests were done and helped to show that and clarify it, that would be very useful for the person to know and for the physician to know, because presumably then that condition could be treated. Is that correct?
It is, but let me rephrase that somewhat.
Okay,
there are some conditions that contribute to substantial cognitive loss that are very treatable. B12 deficiency would be one, not very common cause, but one example of that, and there are other medical conditions. But most disorders, including Alzheimer's disease, do have treatments for them that do make a difference. The trouble is, right now, the treatments we have aren't that good for things like Alzheimer's disease and for some of the other common dementing disorders as well. But there are treatments, and there are management issues and approaches that are important for some of the symptoms.
That's really good for our audience to know, that there are some treatments and there are ways to manage. Even if you do have Alzheimer's disease, suppose that's what you're told after the evaluation is done. Could you take just a moment to share with us what some of those treatments might be?
If we're dealing, for example, with Alzheimer's disease, there are two classes of medications that are FDA approved for symptoms of Alzheimer's disease. They aren't cures. There are no cures. They make people, on average, symptomatically somewhat better.
So there's hope then. The patient and the family can have some hope that there would be a way to perhaps slow the progression of the disease and perhaps bring the symptoms a little bit more under control.
I think that's true. From my perspective, someone who's been in academic medicine for a long time, it's disappointing that the treatments we have really aren't more effective after the last 10 years, 20 years. And it's really important, I think, to try to come up with something more useful for prevention and more effective for treatment.
Well, this is very helpful, very informative. Well, I'd like to shift our focus now a little bit to the Alzheimer's Disease Research Center itself, because it sounds like there's a real relationship here between wanting to know more and being able to enroll in your center. So can you tell us about the center? You know, what is it? What does it do? How can it help people?
So the NIH, through the Institute on Aging, has established a number of Alzheimer's disease centers. When I started my career, there was really very little interest in Alzheimer's disease. Not a lot was known. This was thought to be an uncommon disorder or an unimportant disorder. And I think the National Institute on Aging, in its wisdom, realized that there was an epidemic of dementia that was coming with the baby boomers, and that Alzheimer's disease was the most critical component of that. And they began establishing centers of research excellence, Alzheimer's disease research centers, or in a later iteration, Alzheimer's disease core centers. And there are now centers at universities and other centers of academic excellence in different parts of the country. And Stanford was fortunate enough last year to have been awarded one of the NIH grants to establish an ADRC, Alzheimer's Disease Research Center, at Stanford.
So What makes this center unique? What does this center have that's special compared to some of the other centers that already have existed?
Well, we all think that we're special. I think Stanford brings a number of strengths. There are particular strengths in the clinical neurology of dementia and the clinical neurology of movement disorders like Parkinson's disease, because in our center that's part of what we're looking at in addition to Alzheimer's disease. And also, I think even more so at Stanford, there is such wonderful basic science that's going on in neurobiology, in other areas of basic science, and it's the opportunity to try to attract investigators, some of whom are working in fundamental mechanisms in neurodegeneration, but some of whom are working in other areas, and to try to get them to devote some of their interests and some of their talents to finding underlying fundamental mechanisms of neurodegeneration and to finding pathways to new forms of treatment.
Well, that sounds very exciting.
We are excited.
Now, you did mention, though, something I find a little confusing. You mentioned Parkinson's disease, and yet the title is Alzheimer's Center. So can you help us understand that connection there? What is the relationship?
It's a good question, and we did that deliberately. Parkinson's disease isn't Alzheimer's disease. The two don't look the same. They don't look the same under the microscope. But they're both neurodegenerative processes that seem to involve common mechanisms of protein misfoldings. They also occur often or sometimes together. And although Alzheimer's disease is the most common neurodegenerative disorder, Parkinson's disease is number 2. And since we have the excellence at Stanford, both in Parkinson's disease and investigators looking at underlying fundamental mechanisms, we thought this would be an opportunity to compare and contrast some of the mechanisms involved in these two different but similar also diseases.
Yeah, I mean, it sounds like it can really open some new doors, you know, looking at the two of them and the similarities and differences.
We think that it should. We think that it will.
Yeah, so it sounds like then in the center you're interested in having a variety of people participate. So could you help us understand a little bit more about the focus in terms of the people who might consider enrolling in the center? What kinds of problems or patients or individuals are you looking for?
So each of the Alzheimer's centers does it a little bit differently. So our focus is on Alzheimer's disease and Parkinson's disease. We think it's important to try to follow people over as long a period of time as possible, so people at earlier stages of the illness are sort of better suited for that particular purpose. And we want normal, healthy older people to serve as comparisons for people that have difficulty with mild Alzheimer's disease or milder forms of cognitive impairment that might represent early Alzheimer's disease or mild Parkinson's disease or some sort of...
Okay, so I understand that if a person were to be interested in the center, that they would need to have some evaluation, in some ways similar to what you mentioned before, but perhaps also different in some ways. So can you tell us a little bit about that process?
So if someone were interested in volunteering and you know, we're involved in the study, they would undergo an evaluation similar to what would be done clinically. So a neurological examination, some neuropsychological testing to look at memory and cognition. But also we're looking at other kinds of laboratory measures. So a blood sample, in some instances a spinal fluid examination, in some instances a skin biopsy to look at some of the skin cells that can be used to establish cell lines that can be used in certain kinds of research. And we want, and I should also mention that imaging at Stanford is very strong, and there is an important neuroimaging component of the brain.
Mr. Wolford, hello.
Hi, how are you?
Hi, I'm Nusha Ascari with the Stanford Alzheimer's
Oh, I'm glad to
Disease Research
meet you.
Center. Pleased to meet you. Come on in. I'm going
Okay.
to take you back to see Dr. Henderson.
All right.
Mr. Wolford?
Yeah.
Oh, hi, I'm Dr. Henderson.
Oh, hi.
Yeah, thank you for coming. Have a seat.
Oh, I'm delighted to be here.
We're very appreciative of your willingness to consider volunteering for the Alzheimer's Disease Research Center here.
Well, I mean, I thought it would be a good idea to learn more about what my problem is and get involved in the research.
So we're very grateful. And your doctor has told you that you have something called mild cognitive impairment. Does that sound right?
Yes, he mentioned that, yeah.
Yeah, so what is that about?
Well, I have trouble remembering things. My wife will tell me something to do, and 20 minutes later, I can't remember what it was that she told me to do.
So Mr. Wolford, now what I want to do, two different things. One is
Okay.
to ask you some more questions about your memory
All right.
and things like that, and then we'll put you up there on the table, and I'll look at your eyes and check your reflexes and do that kind of an exam.
Yeah, okay.
So memory, let's just tell me what month and what year this is.
Well, this is April, and April, I think it's the 10th. The 10th or 11th.
And what year?
Oh, it's 2016.
Yeah, good, okay. Perfect, perfect. Now, I'm going to give you a name and an address to say after me, and I'll ask you to remember it for several minutes.
Uh-oh.
Here we go.
Okay.
Sam White, 64 Maple Street, Seattle. You say that.
Sam White, 64 Maple Street, Seattle.
Good, good. I want you to count backwards from 20 to 1, starting with 20.
20, 19, 18, 17, 16, 15.
Good. One other thing to do backwards. I want you to say the months of the year in reverse order, starting with the last month, and then go back to the first.
So that would be December, November, October, September, August.
Now, what was it I asked you to remember for me?
Oh,
It was a man's name and address.
it was Sam White, 84.
There you go. I want you to do something else for me. I want you to draw for me a clock. Draw the face of a clock, put in all the numbers, and set the hands at 10 minutes past 11.
Oh, okay, I should be able to do that.
You can set it up.
10 minutes after 11, is that what you said?
Draw the face of a clock, put in all the numbers, and set the hands at 10 past 11.
10.
Straight ahead. Okay, now this side. Look right at my eyes, point to my finger when you see it moving. Good. 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 Follow my finger with your eyes.
For a long time.
So just relax here.
Okay.
There we go. Relax, relax. Over here. Good. Same thing. Good. Go like this for me. Real fast, real wide. Back.
Okay.
Just walk naturally.
All right.
And come on back. Good. One more time. Open your eyes. Good. Well done. I want to thank you for coming in, for talking to us and
pleasure.
putting up with all this.
Yes, it was really interesting, and thank you for doing the exam. That was very nice.
Yeah, thank you. Great.
Well, this is really wonderful. I really appreciate this.
Good. So let's go see if we can find out where your wife is.
Okay, yeah, that would be good.
Promote knowledge and give back to society, perhaps in ways that they hadn't thought of before, by volunteering for this center.
And we hope that people will volunteer. We ask a lot of our participants. They are followed over time. The initial evaluation takes place over 1 day, but sometimes 2 days, period of time. But I think it's important. We need to find better forms of prevention, better forms of treatment. We need to find a cure for this disorder. And it's only by having people participate in this way, where we get as much information as possible over time, that I think we'll be able to contribute importantly to the national effort to find a cure for Alzheimer's disease and Parkinson's.
All right. So if I were thinking about becoming a volunteer for your center, you said that you were interested in people without cognitive impairment as well as people with discernible cognitive impairment.
You would be at the top of our list in the former category.
So what would how would I likely benefit from signing up for your center? What would be the benefit to me? Is there any particular value to me as an individual at that point in time?
I try not to oversell the benefit, but I think the fact that one is doing something important to advance knowledge in an important field that affects a lot of us, to find a cure during our lifetime, or if not our lifetime, then a cure that will be available for our children. I think at the same time we try to provide it, to give as much back as we can to our participants, to keep them informed about latest research findings, to offer resources and referrals where we can. But I think the underlying motive is often altruism.
Well, I think that's probably a very good place to help people understand what they can do if they would really like to volunteer, or if they have questions about the center. So I want to thank you very much for the time that you have spent and your very clear explanations of a complex area, very complex. And I would like to end our show by asking people in our audience to consider, what can you do to help us in this battle against Alzheimer's disease? Alzheimer's disease is a terrible disease in all of its, and the associated dementias as well. So I'd ask you to consider volunteering, because you may very well fit into one of the categories that Dr. Henderson talked about. If you're not sure, that's fine. If you look at the lower third of your screen, you will see our phone number, and we invite you to call that number and speak with Christina. Christina will be happy to answer your questions, and she will let you know if you would be eligible for enrollment in the center. We hope you will take this opportunity. We hope that we can all, working together as a community, eventually create a world without Alzheimer's. And the way to do it is through research. That really is the path that we need to follow. And so we invite you to consider seriously this invitation. And thank you very much, and we look forward to seeing you next time.